Go. Start.
Hello.
Dr. You can go ahead.
Am I audible?
Yes.
Yeah, you are audible.
Okay. May I start?
Yeah, go ahead, Shivon.
Good evening, everyone. I'm Dr. Shivon De Silva, primary DNB, first year from Shankarai Hospital, Coimbatore. I would like to welcome our moderators for today's case presentation. Thank you, Dr. Vidya, consultant at Shankarai Hospital, Bangalore, and Dr. Palak, consultant at Shankarai Hospital, Hyderabad, for taking the time to mentor this session. May I begin the presentation?
Yeah, go ahead.
Okay. So my patient is an 8-year-old female, third grader, residing at Coimbatore, brought to pediatric ophthalmology clinic by her parents for routine checkup. The child was apparently all right 3 years back when she visited her ophthalmologist for diminution of vision, and her parents were informed about her squint. Since then, her mother notices face turned to the right and outward deviation of her left eye, which is non-progressive. History of spectacle
Yeah, can
use.
you wait, Dr. Shivon?
Yes.
Here, no, you have to elaborate upon that. This is the history of the presenting illness. The chief
Yes.
complaints are, what is the chief
Diminution.
complaint here? It's a diminution of vision.
Vision. Yes, ma'am.
In the history of presenting illness, you have to take up each and every complaint and then elaborate it.
Okay.
Okay. So here you are saying there is a diminution of vision. Then you have to elaborate on this symptom. Yeah.
Okay, ma'am.
Yeah.
So the chief complaints were diminution of vision for a week, and so the child told her mom that she was not like able to see the board properly in school. So that's when her mom took her to the ophthalmologist. This was 3 years back. So she
Okay.
visited her ophthalmologist for a routine checkup, and there her parents were informed about her squint.
Yes.
Since
So
then,
now the patient was brought to the hospital with the main complaint of, is it the defective vision or for the squint?
just for routine checkup, ma'am.
Okay.
Just as a
Yeah.
routine checkup, she was brought to Shankarai Hospital, Coimbatore.
Okay.
So there is a history of spectacle use for 3 years with no
Yeah,
change
you are
in
saying that there was a face turn to the right, right?
yes.
So
So ever
you
since
have to elaborate on that and then elaborate on the outward deviation of the left eye, which was noticed by the parents.
okay, ma'am. So her mother noticed her face turning to the right and the outward deviation of
No,
left.
whether the face turn to the right was noticed throughout the day, whether it was intermittent, any
Okay,
diurnal variation was seen by the parents or not.
okay, ma'am.
Okay,
So
and whether it is more for the distance or for the near. When the child was reading her book, whether she was able to read without a face turn, whether the child is seeing the TV with a face turn.
yes.
All
Uh,
these things should be elicited.
okay,
Okay?
ma'am. Okay.
Okay. And coming to the outward deviation of the left eye, you have written it is to be non-progressive. So
Yes,
whenever
ma'am.
you described about the deviation of the eye, you have to say again whether it is intermittent or constant deviation noticed by the parents, whether one eye is always involved when compared to the other eye, any diurnal variation noticed, all these things to be included there.
Okay, ma'am. So the outward deviation of the eye was constant, and I didn't ask about diurnal variation.
Okay. And for the
And
distance or for the near?
it is they noticed it for near, like when she used to use the tablet. That time they
Okay.
noticed it.
Okay.
That's when her
Only
mom
at the
noticed.
time of a near work, the child was observed to have the squint,
Yeah,
right?
as per what her mom told me. Yes,
Yes. Okay. Go ahead.
there was history of spectacle use for 3 years with no change in prescription.
So
There was
here
no.
also, whenever you're seeing the spectacle usage, the child is using the specs for 3 years time. So
Yes.
with the specs, what happened to these two symptoms which you have already described?
Ma'am, they were still there. They were still
Yes,
present.
that you have to
Okay.
specify here. So
Okay.
there was no change in the face turn even with the glasses on. There was no change in the deviation even with the glasses. That has to be described here.
Okay,
Okay.
ma'am. Yes. So history of spectacle use for 3 years, um, and there was no improvement or worsening of the symptoms, and no change in prescription over the 3 years. There was no history of relieving or aggravating factors. No history of patching eyes. No history of double vision, eye strain, watering or headache. No history of ocular trauma. No history of any other ocular surgery. No history of convulsions or focal neurological deficit.
So you told me that they have consulted the doctor before 3 years' time,
Yes, ma'am.
and whether any exercises were given for the child. Whenever there is a squint, there are so many people who give the exercises for the children, right? So
Yes.
one is the patching therapy, another one is in the form of exercises. Whether any exercises was prescribed?
No, ma'am.
Nothing.
None were
Okay.
prescribed. Yes. So
Okay.
that's why her mum also came to the hospital because she wanted to show another ophthalmologist as well.
Okay. Now here, why have you asked for the convulsions and the focal neurological deficit history?
Ma'am, to rule out any acute onset of strabismus, any acute onset squint.
Very good. Any acute onset of strabismus associated with the neurological diseases.
Yes, ma'am.
So what are the history you will ask along with this to elicit whether it is due to that? In
History
children,
of
which is common.
immunization.
Yes, very good.
Yes.
You have to ask for the history of immunization and, as you told, history of
Viral illness.
fever.
Yes, fever
Fever.
virus. Right.
Fever. So, any history of fever, any viral infections per se, or any vaccination priorly can lead to the onset of a squint in children. So, that also need to be considered here. Yeah.
Yes, ma'am.
Okay. Yeah. Go ahead.
Uh,
Shivan, can I ask you a question? Can you go back to
yes,
the
ma'am.
previous slide?
Yes, sure, ma'am.
What is the relevance of age while you're taking history for strabismus?
Ma'am, strabismus sometimes, like congenital strabismus, will present earlier or at birth. It will be noticed by parents, whereas a different subset can be noticed at a later age, and hence age becomes important in differentiating some of these.
Which
Like for example,
squints will be,
For
yes,
example, a congenital sixth nerve palsy will be noticed earlier by the parents versus like a Duane retraction syndrome, which will come a little later, um, or accommodative esotropias, exotropias.
what is the age of onset of DRS, Duane's retraction syndrome?
After 5 years,
It's a congenital condition.
yes, ma'am.
What is meant by congenital?
Since present since birth.
Yes. So, congenital means it's since birth. But usually, when it will be noticed? Any idea?
In like after 3-4 years.
After 3-4 years?
One, um, 1 to 2 years.
See, it depends on the amount of deviation. See, usually the child's fixation will be wandering till about 2 months of age. After 2 months only, the child will start fixing. When the child starts fixing, you will be able to notice a squint in the eyes. Okay.
Okay.
Yeah,
When
go
do
ahead.
other kinds of squint present? Example, when do an accommodative esotropia patient comes? When does an intermittent exotropia patient present? Common age groups, age range.
Uh, Accommodative esotropias will present um, around 3 to like I'm not sure actually.
It's around 3 to 5 when you commonly see accommodative esotropias. Intermittent XT is also around 2 to 5 you can start noticing. Again, what are the causes of abnormal head posture?
Abnormal head posture could be the ocular causes, and in ocular causes it could be due to um, dip, um, squint to maintain the binocular single vision.
Yes, to maintain binocular single vision. What would be the reasons why a patient would adopt a abnormal
To
head posture?
avoid diplopia.
Which conditions the patient will have AH?
Um, AHP would be present in um, Duane retraction syndrome with uh, primary esotropias or exotropias. Um,
Any other conditions? It basically comes in incomitant strabismus. Okay, you know what an incomitant strabismus is?
Incompetent strabismus is when the secondary deviation is greater than the primary deviation. Uh, it's suggestive of incompetence, and it could have a paralytic or restrictive pathology.
Yes. So paralytic and restrictive strabismus will have an AHP. Apart from that, which other conditions very commonly the patient presents to your clinic?
Um,
Your patient has been using that for 3 years.
spect-
Refractive errors.
refractive errors.
Hmm?
Yes, ma'am.
Any other reason?
Um,
Nystagmus. Why would a patient have AHP in nystagmus? To use the null zone. What is the null zone? Null zone is the point where the frequency is going to be less. So the patient uses the null zone to fixate. That is when they will have an abnormal head posture. Okay.
okay.
Yeah. Why would you want to ask about ocular surgery? Which ocular surgeries are causes to give you eye misalignment? I mean,
Um,
which particular ocular surgeries are known to develop strabismus?
mm,
Palak, she is a first year student. I think she may not be able to answer all these things.
Sure.
Yeah. So actually, whenever strabismus surgery is done, the consecutive esotropias and exotropias can occur. So only we need to ask for a history of ocular surgery here. Okay. Shall we move ahead, Palak?
Yeah, sure, ma'am.
Yeah. Go ahead, Dr. Shwan.
she's a first-born child of a non-consanguineous marriage, full term, born by cesarean section, weighing 3 kgs. There is no history of delayed developmental milestones, and she's fully immunized for age.
So why you have to ask for a delayed milestones here?
Some strabismus come with syndromes, and some of them can present like with delayed milestone. Like for example, in Downs, they may
Very
have a
good.
delayed milestones.
So whenever there is a syndromic conditions or with a neurological disorders, they can present with the delayed milestones and they are more prone to develop a strabismus too. So it is an important history to be elicited in the birth history. Okay. Yeah. Go ahead.
There is no history of squint noted in other family members.
So why you have to ask that? Why in family members?
because strabismus also has a familial inheritance.
Yes.
So hence, history of squintin family members.
Yes. Can you name a few which can occur in families?
Um, Ma'am, in one is infantile esotropias.
Little rare. Of course, accommodative esotropias can occur. Then Brown syndrome,
Browns,
Duane syndrome,
Duane syndrome as well.
CFEOM, all these things can occur in the family. So here family history plays an important role. Okay. Yeah.
Do you know the importance of prematurity in pediatric ophthalm? What would prematurity lead to?
Um,
What is the common condition that you are worried about when a child is premature?
with respect to strabismus, pediatric ophthalmology,
Pediatric op-
retinopathy of
ROP.
prematurity.
Yes. Yeah, you can go ahead. You can go ahead.
Okay. The general
Yeah.
examination.
Before going into general examination, you summarize what is the positive thing you have seen in the history.
So in the history, the child um, has an abnormal
8-year-old
face.
child.
8-year-old child,
Hmm.
school going with abnormal head posture and outward deviation of her left eye, with history of spectacle usage
Noticed since?
noticed since 3 years, and
No, noticed since 5 years of age, according to your history,
noticed since 5 years of age,
by the
which,
parents. Hmm.
which is non-progressive,
Hmm.
with no aggravating or relieving factors.
Hmm.
She has history of spectacle usage, uh, which has no improvement on her symptoms, and no change in her
No. See,
glasses.
positive history means you have to just describe only the AHP and the outward deviation of the eyes. Of course, with the spectacle usage also, the deviation is remaining constant. That's it. Yeah.
Okay.
So
So,
now we have already discussed about the causes of AHP. AHP is over. Now, what are the causes of an outward deviation of the eyes? What would you think of when a child presents to you with the outward deviation of the eyes?
so it can be accommodative exotropias,
What is it? Accommodative exotropia?
intermittent
Yes, it is an
exotropias,
intermittent exotropia. Very
exotropias.
good. Yeah. Then,
Um, then Duane retraction syndrome.
very good. Yes.
Um,
Anything else? In children, whenever you see an outward deviation of the eyes, there are few more things we would like to uh, probably note it down in the sense. One is an intermittent exotropia. Then, as you told, the advanced retraction syndrome. Then, as we already described, it can be a consecutive exotropias following the surgeries in the early childhood days.
okay.
Then it can be a sensory exotropia. Do you know a sensory exotropia? What does it mean? Any idea?
Uh,
Here, the vision will be
Congenital
poor in one
cataract.
eye. Yes. So, when the vision is poor in one eye, then the eye might deviate out with the time. That also can present the similar way with the exotropia. Then, of course, the congenital third nerve palsy presents with an exotropia. Of course, it will have all other features of the third nerve palsy. Okay.
Yes.
And of course, the CFAOM, congenital fibrosis of the extraocular muscle, can also present with the exotropias. Okay, fine. Go ahead.
So the general examination was within normal limits. Systemic examination was also within normal limits. Coming to the ocular examination, right face turn was noted and facial symmetry was maintained. On sensory examination, Worth 4 test showed fusion for near and distance. Stereopsis by TNO was 120 arc seconds and
Uh,
fixation was
just
10 arc
wait, Dr. Shivun. So, whenever we say a face turn, we described it in terms of degrees.
Yes, ma'am. I
Yes, how much is
mentioned
the degree?
it's 15 degrees with goniometer.
Okay, so what are the ways to measure an abnormal head posture?
Ma'am, one is using an orthopedic goniometer.
Very good.
Another
Okay.
would be like two rulers and a protractor.
Yes,
Then cervical range of motion
yes,
devices.
we can use that. Yes, yeah, yeah,
So
go ahead.
she had a right face turn and facial symmetry was maintained. What 4-dot test showed fusion for near and distance. Stereopsis by TNO was 120 arc seconds. Fixation was central, steady, and maintained.
So have you
On
checked for the
refraction,
fixation
She
here?
wants when you
yes, ma'am.
Have you checked for the fixation? Have you checked for the central fixation?
By allowing the patient to sit comfortably,
Hmm.
stabilizing the head, and
Hmm.
then shining a torch
Hmm.
and seeing that the child, the way that the child is fixing on the light, and that it's steady and maintained.
No, central fixation, how have you checked? So you're saying that you are shining the light in front of the eyes, right? In front
Yes,
of the face. And will you check it monocularly or binocularly?
monocularly.
Okay.
Basically, you have to understand that CSM has got three features, right? Okay. One is central, second is steady, and third is the maintenance. Okay. Amongst these three steps, central and steady is done under monocular conditions. So when you're checking for a central fixation in the left eye, you have to occlude your right eye with the help of a patch or with the help of occluder and shine the torch right in the glabella and look for the fixation. If the child has got a good vision, the child will fixate at the light. Okay. The same thing can be repeated with the other eye patch. Similarly, for steady maintenance, steady fixation, what you should do is similarly you patch one eye and then right from the central position, you just follow the objects. You take the object to your right or left, depending on which eye is patched, and ask and just find out whether the child is following the objects or following the light source. So both these tests has to be done under monocular conditions. The only test which is done under binocular conditions is the maintenance
Maintained.
of fixation. Yes, but understand CSM. Okay.
Shivon, when you do the word for dot test, have you checked it with the EHP or with the forced primary position?
Ma'am, after correcting the AHP, I
With the EHP. Yeah, so you do mention that as well.
okay, ma'am. Refraction was uncorrected visual acuity was 6.9 in both eyes, and her best corrected visual acuity was 6.6 with minus 0.75 diopter sphere in both eyes, and her near vision was N6 N6.
You told me that the child is already wearing the glasses, right?
Yes, ma'am.
What is the power of the glass? Have you checked for that?
Minus yes, ma'am. It was minus 0.5.
Okay, fine. Go ahead.
So on motor evaluation, there was a face turn of 15 degree measured by a goniometer. The corneal reflex in the left eye is seen nasally at the pupillary margin, suggesting around 15 degrees of exotropia. The cover test showed left eye exotropia. Alternate cover test, the secondary deviation appeared larger than the primary deviation.
So what is meant by a secondary deviation?
So, ma'am, secondary deviation is when the deviating eye is fixing and it is measured by placing prisms over the normal eye. When the deviating eye is fixing, the angle of deviation, that is the secondary deviation.
It's not the
So
deviating eye, it is the affecting eye. Okay.
Affected.
affected.
So say for this case, for example, this is a left eye DRS, right?
Yes,
So
left eye.
when the child will have a mild exotropia, when the right eye is fixing, the affected eye is left eye. Okay.
Yes,
When you forcefully make the left eye to fix, that is affected eye to fix, the amount of deviation in the right eye is the secondary deviation,
deviation.
so which will be more than the primary deviation in case of a either a paralytic squint or a restricted squint. Okay.
So here, no, before saying about the extraocular muscles, if you are commenting about the alternate cover test, the secondary and the primary deviation, it doesn't make a sense. So you should say prisms placed in front of the left eye is how much, prisms placed in front of the right eye is how much. Because still we haven't come to the conclusion saying the left eye is the affected eye. Till you mention about the extraocular movements, we cannot really assume that the left eye is the affected eye here. Okay. So when you are describing it priorly, you say the prisms in front of which eye, what was the deviation observed. Yeah.
Okay.
Okay. How will you do an alternate cover test?
Ma'am, by alternatingly covering the left and right.
How do you do a cover test? What are the prerequisites of a cover test?
Okay, so for the cover test, the patient should have a good visual acuity and fixation of around 612 to 618. Free extraocular movements.
Good.
And
Yes.
yes.
What should they be fixating at?
Foveal fixation, yeah.
Yes.
Pardon, ma'am?
What should they be fixating at?
Near target.
At what distance?
33 centimeters.
And
the eye
and one more distance.
Distance.
Distance is 6 meters.
6 meters, yes.
It is the ideal target to do a cover test. The letter size. 6'9".
6'9".
Why do we make the patient read when you are doing your cover test? What's the purpose of making them read? Because your accommodation is controlled.
Yes. So on the prism bar cover test, the primary deviation for near was 20 prism diopters base in, and for distance was 15 prism diopters base in. Secondary deviation for near was 30 prism diopters base in, and for distance was 20 prism diopters base in.
So how will you do the prism bar cover test?
Prism bar cover test is done. I did it after correcting the abnormal head posture and using refractive glasses.
Very good.
I did it for near and for distance.
Good.
So using like the occluder, I did the alternate cover test while placing prisms.
So first you do the alternate cover test.
Yes.
Then you start placing the prism there.
Yes, ma'am.
Why you have to first do the alternate cover test and then place the prisms? Why can't we directly start placing the prisms there and measuring?
The alternate cover test, we can diagnose, like confirm the tropia and.
Okay, and also we are dissociating the eyes so that we will have the maximum deviation in the eyes. We will be able to measure the maximum deviation the eyes have got. Okay, go ahead.
So, Neha, can you go to the image? So, extraocular movements in primary gaze showed 15 degrees of exotropia in the left eye. On dextroversion, left eye shows decrease in the palpebral fissure height with upshoots and globe retraction on adduction. On dextro elevation.
And also there is a slight limitation of adduction you can see.
Yes, ma'am.
Yes, so you have to say
Yes.
that.
Slight
that
limitation
also.
of adduction.
Yes.
On dextro elevation, upshoot can be seen in the left eye. On dextro depression is a normal. On levo version, left eye shows limitation of abduction of around -3 and increase in the palpebral fissure height. And both levo elevation and levo depression appear limited. Elevation and depression were normal. Ductions in the right eye were normal. And in the
See,
left
one
eye,
more thing. Here on levo elevation and levo depression, the limitation of abduction is less than in the levo version.
yes, ma'am.
Have you
It's
noticed
about
that? It is
yes,
about -3 you
-1.
told in the
Yes.
levo version, but levo elevation and levo depression, it's nearly only -1.
Yes, ma'am.
Yeah, yeah. Why is it important here? Any idea? See, it's because of the anomalous innervation of the lateral rectus. You can see this, what to say, more limited abduction in the levo version when compared to the elevation and depression. Okay.
Okay. And so there's an abduction limitation in the left eye of around -3. The rest of the adductions were normal.
And adduction limitation you told now.
And adduction limitation, yes.
By about -half.
Half. The anterior segment evaluation was within normal limits, and posterior segment evaluation was within normal limits. So, ma'am, after the examination, my provisional diagnosis is a left eye exotropic Duane retraction syndrome with upshoot globe retraction and both eyes simple myopia.
Okay. So what is the differential diagnosis here?
Ma'am, it could congenital third nerve palsy, but there are lots of features suggesting pointing more towards DRS than congenital third nerve palsy. That is the globe retraction, the upshoots, abduction limitation,
Yes.
and decreased palpebral fissure height on abduction. All these are more suggestive of DRS
Okay.
than congenital third nerve palsy.
So
What is the most common differential diagnosis of a DRS apart from third nerve palsy, other than third nerve palsy?
So if it was an ESO DRS, then I would put a congenital sixth nerve palsy as my differential, one of the different, like I would have to rule that out and only then say this is DRS and
How will
not
you rule out a congenital sixth nerve palsy with the ESO DRS?
Okay, so in congenital sixth nerve palsy, the angle of deviation corresponds to the like the limited eye movement, whereas in DRS it does not. The angle is very small.
Very good.
Then, along with other features like a decrease in palpebral fissure height on adduction, globe retraction, upshoots, these are more suggestive of DRS than a congenital sixth nerve palsy.
Very good. Yeah.
which is a common diagnosis? That is, if a child is presenting with an exotropia, what will be your first diagnosis there? A child is simply presenting with an exotropia. So I mean to ask, which is a common presentation of exotropia in children?
Refractive error.
No. Exotropias. What is? Yeah,
Exotropia.
exactly.
Yeah,
Intermittent exotropia is the most
Intermittent
common type of exotropia.
exotropias.
that is the commonest form of exotropia in children. So whenever a differential diagnosis is asked, you should go from the commonest one to the rarest ones. So first you have to start with the intermittent exotropia. So why is this case not an intermittent exotropia?
It's the deviation
It
is
has the
present
features of the
constantly.
DRS.
Yes.
It has the features of the DRS. And intermittent exotropia, will it have a limitation of movements? Usually no, unless and otherwise it's a very gross deviation present. Yeah. So
Yes,
it is, since it has the features of the DRS. So what are the main features of DRS? To say a patient has a DRS, which feature should be present there?
decrease of palpebral fissure height, globe retractions, upshoots on adduction, and horizontal like abduction or adduction deficits.
Yes. So there should be limitation of movements, limitation of the extraocular movements with the retraction of the globe.
Yes.
Yeah. So because of this, there will be an AHP which will be automatically there.
Yes.
Of course, there is one condition which is an orthotropic DRS where we don't see an AHP so much, but still,
Yes.
at your level, you have to say there is a retraction of the globe along with the limitation of the movements, which should be there to say a case to be a DRS.
Yes.
So basically, intermittent exotropia is a committant strabismus. Okay.
Yes.
So what is committant and incomittant? What is the difference?
Committant is when the primary deviation and secondary deviation are.
That is one of the features. Okay, secondary deviation more than primary deviation is one of the features of a incomittant deviation. The basic definition for committant deviation is the deviation should be equal in all positions of gaze, whether it is
Yes.
primary position, lateral version, up gaze and down gaze. So this case, why, as Vidya asked, why is it not intermittent exotropia? Because the deviation is not uniform in all positions.
All the
Okay,
cases.
the secondary deviation is more than primary deviation, which is against a committant deviation. So intermittent exotropia is basically a committant deviation.
So what are you going to do for this case now?
Ma'am, in this case, because it's an exotropic Duane retraction syndrome, an LR recession with Y splitting for correcting the upshoots
Very good. Yes.
would be recommended.
Yes.
Surgery
So
options.
surgical management is recommended for this patient.
Yes.
So in a DRS case, why we should correct the strabismus? What is the indication, surgical indications of correcting the DRS here?
Ma'am, one is a abnormal head posture of more
Yes.
than 15 degrees, severe globe retraction, severe upshoots, downshoots, primary gaze exotropias or esotropias.
Very good.
Very good.
Very good. So
So
here
that
it is a strabismus along with the upshoot, which is the main reason we are going to do surgical correction for this child. Okay.
Shivon, what is the etiology of DRS?
Ma'am, is actually it's a part of the congenital cranial disinnervation disorders, where there is a malformed six nerve nucleus, and because of which
Aplasia.
there are it's a innervational deficiency to the lateral rectus. It can also have paradoxical innervations to lateral rectus by third nerve, and they manifest with different features seen in DRS.
What would be the reason why they develop an upshoot? Why does the
It
patient?
is it's slippage of the globe,
Hmm.
like from the tight from the contracted lateral rectus, the tight lateral
So in
rectus.
adduction, both your medial and lateral recti are contracting, which leads to the slippage of globe due to the bridle effect.
Yes,
Yeah.
leash phenomenon.
So to counteract this, what are you planning to do?
The Y split,
Hmm.
where yeah.
Right. What should you explain the patient? What kind of expectation should they have while you are taking up the patient for the surgery?
We have to explain to them that we are like when we correct this condition, we are not going to be correcting the abduction deficit. We'll only be like for cosmesis, we are going to make the eyes orthotropic, and because the pathology is in the brain, so we cannot correct that abduction deficit. Although there are procedures to slightly correct that abduction deficit, but mostly we are correcting the primary gaze deviation.
What
Very
procedure do
good.
you use to correct the abduction limitation? Now that you said,
Vertical recti transposition surgeries.
would you do a vertical recti transposition in all cases? Advanced question again.
Probably not.
You won't do when there is a lot of globe retraction and upshoot and all.
Shoots.
Vertical recti transposition is indicated in a typical ESO-DRS where there is a simple ESO-DRS, not associated with other complicated procedures like severe globe retraction. The results are not good. Okay. What are the surgeries you do when there is a severe globe retraction?
Both LR and MR recession, because globe retraction will
This
occur
case has
because of
got an LR
co-contraction.
recession.
Very good.
Case has got already an exotropia. So if
Yes.
your MR recession is will aggravate an exo deviation, so how will you plan? Just give a thought.
So can you repeat the question, please?
This case already has got an exotropia. So
Yes.
exotropia, the surgical procedure of choice is LR recession. You
Yes.
wanted to do a MR recession as well to correct the globe retraction. So that will aggravate an exotropia, right?
Yes.
How will you plan in that case?
Like, is it by asymmetrical?
Very good.
Asymmetrical recession of both.
Yes. So we
LR
do an
should be assessed more.
asymmetrical MR and an LR recession so that we reach the orthotropia here.
You do a small MR recession to just to
And
release the tight MR, and then you do a large LR recession to balance the exotropia, which can be caused by a recessing the MR in this case. Okay, so it's called a differential or a asymmetrical MR and LR recession.
How will you say that these are upshoots only? I'm saying it's an inferior oblique overaction. Can it be an inferior oblique overaction here?
In DRS, there can be inferior oblique co-contraction along with lateral rectus.
So how will you differentiate between the two?
Such cases will also have in primary gaze some hypertropia.
There are
No.
two types. There is one mechanical and innovational.
Yes.
So how will you differentiate between these two? This case you are saying it is a mechanical upshoot. I am saying it is an innovational upshoot. How are you going to contradict? Pardon?
It's only coming when the eye is adducting.
No.
See,
So
in
when
mechanical upshoot, whenever the globe is going into that direction, it will automatically, sudden movement of the eye will be there. Sudden movement of the eye in the upward direction. But in an innovational upshoot, it will be a slow movement into that overacting muscle. That's how you differentiate. When you see a case of a mechanical upshoot, you will never forget that. It will be a sudden movement. But in innovational upshoots, it will be a very slow movement into the direction. Okay, that's how we
Mechanical
differentiate.
upshoot is because of sudden slippage of the eye when it comes to an attempted adduction. The globe suddenly slips due to the tight LR. So it will be sudden movement. Okay.
What are the three types of DRS you know of?
Ma'am, Huber's classification of DRS. Type 1, in which there is an abduction deficit and face turned to the same side with globe retraction and decreased palpebral fissure height on adduction. Type 2 is an adduction deficit with face turned to the opposite side. Type 3 is both adduction and abduction are limited.
Huber's classification is based on what, Shivan?
EMG findings.
Which is the commonest form of DRS?
Type 1.
Rarest?
Type 2.
Rarely diagnosed is type 3. Sometimes we miss to diagnose type 3 because sometimes we'll miss the adduction. Just like what Vidya told, no, -1 is sometimes miss it because we'll be concentrating more on the shoots. Will be subtle minus off to 1 adduction restriction will be missed usually. So actually type 3 is also very common, but only thing is we'll miss sometimes. So what is the common cause of amblyopia in such children with DRS, if at all they have amblyopia?
So the anisometropic
Why not a
amblyopia.
strabismic amblyopia?
Because the abnormal face turn will correct. They have the abnormal face turn to maintain the binocular single vision. So it shouldn't be strabismic amblyopia.
Yeah, very good.
Very
So
good.
most commonly, usually whenever they think of a strabismus case, they think of a strabismic amblyopia. In a DRS, it is usually a non-strabismic amblyopia, non-strabismic cause of amblyopia. And what is the most common cause of refractive error? In this case, it is causing amblyopia. Yeah, so NSO hypermetropia. Okay, so that gives the emphasis that all cases of DRS, we have to do a complete cycloplegic refraction to find out if there is any refractive error or if there is any anisometropic refractive error.
What is the latest classification of DRS?
It's based on the primary gaze deviation. So it's
Very
either
good.
esotropic DRS, exotropic DRS, or orthotropic DRS.
Yes, very good.
Name some syndromes associated with DRS.
Golden hour syndrome, where there'll be limbal dermoids along with skin tags as well as cleft, like as then Holter Arm syndrome, which is a aplasia or hypoplasia of the radius along with congenital heart defects, Klippel flare, Wildervanck syndrome.
Like Klippel-Flail, Wildervanck, and Golden Nurse.
What other surgery can you plan for this case? You told LR recession with a Y split. If the exotropia is quite large, what other surgery we can plan? Any idea?
Yeah, ma'am. So when the exotropia is very large, that retro equatorial myopexy, the fadenization procedure, like
More
you
than
have
that. Anything else?
LR, like
Yeah, very good.
LR disinsertion, and you'll fix it to the lateral orbital
Wall.
yes.
Very good.
Periosteal.
Very good.
Fixation of
It's a
wall.
lateral
Very good.
periosteal fixation. Okay. So when we do a lateral periosteal fixation, we usually combine that with a vertical rectus transposition to give abduction to the child. Okay.
What is the recent surgical procedure which is done to improve the abduction in case of DRS, apart from VRT?
Modified Nishida technique.
Very good.
Very good.
Too good for a first year student.
Yeah, even I was thinking the same thing, sir. She has read a lot. Good. Keep it up, Shivu.
Yeah, thank you, ma'am. Ma'am, I actually had one question in my case.
Yeah.
So in my case, this would be a type 3 DRS?
Yes.
Type
It's
3
a type 3 DRS.
exotropic DRS, right?
Yeah.
I was a little confused because there were so many features of type 1, but then like exos should not
Yes.
type
Yes.
1.
It is a type 3 DRS. There is an adduction
It is type
limitation
3.
also. So it's
Yeah.
type 3 DRS.
Okay.
So your diagnosis will be a type 3 Duane's retraction syndrome or an exotropic Duane's retraction syndrome with the upshoot, with the AHP and upshoot, with a simple myopia in both eyes.
Okay.
Because that will draw us towards the surgical management of this patient. So when you say, you should say in toto everything.
Anything else, Palak?
So what are the features of intermittent exotropia? Just into the differential diagnosis part.
Intermittent exotropias.
I told you, no, we have to concentrate on the history a lot. You have to elaborate the history. Why? Because certain features of intermittent exotropia you will get from the history itself. The positive history will be there. Now, what are the positive history you will see in an intermittent exotropia? How will the child present? Okay. Usually it starts around 2 to 5 years of age. And it starts with an intermittent deviation. As the name suggests, it's an intermittent exotropia, right? So the child will have on and off the squint. The parents will say that only when the child is very tired or ill or looking, daydreaming or looking at the far off distance, the child may have a squint in the eyes. And the child may have a closing of one eye on and off. So this is again a positive history which we will get whenever the parents are sharing the history to us. So these will point towards an intermittent exotropia. So when you look at the child may be orthophoric. When you look at the child may be normal. You may not be able to see a squint in the child. When you do the cover test only, it may break up and you will be able to see a squint. Yeah. If the control is very, very good, with the repeated cover test only, you'll be able to elicit the squint there.
Okay.
I would request the audience to put your questions in the chat box, if any.
The typical exam question is like DRS, which eye is most common?
Left eye.
Male or female?
Female.
So that you should know. And how many percentage is bilateral?
Only 20%.
Yeah. So all these things they repeatedly ask in most of the exams. Okay. Left, female, and 20% is bilateral. Are there any questions posted in the YouTube platform? I think if there are no questions, then
Shivon, what are the cardinal gaze positions?
Ma'am, there are 6 cardinal gaze positions. That is dextroversion, dextroelevation, dextrodepression, levoversion, levoelevation, levodepression.
And what are the yoke muscles?
Yoke muscles, they're basically muscles that are used to perform conjugate eye movements.
Example?
So, for example, for dextroversion, in dextroversion, it is the yoke muscle will be the right lateral rectus and left medial rectus.
Yes. What is the Sherrington's law?
Sherrington's law of reciprocal innervation is that when in the same eye, when a muscle innervation to a muscle is increased, proportionally there'll be decrease innervation in its antagonist, in its corresponding antagonist.
Any more questions? Vidya ma'am, Rajesh sir?
I think we have covered. Just
Yeah.
need to find
we
out
have
whether
covered.
there are any queries from the YouTube platform. If there is nothing, then we can call it a day.
Present, there are
Tejas,
no
is there?
questions, sir. Radhika has this
Okay,
side.
fine.
Okay.
Okay. Then we'll.
We'll
Nice.
wind up
Thank you,
session.
Dr. Shivon,
Thank
Dr.
you.
Palak,
Thank you,
and
Thank you,
Dr.
Dr.
Vidya. It's a nice
Shivon.
presentation.
Thank you,
Yeah.
sir.
So,
Good
Thank you
job,
for your
Shivam.
time. Thank
good
you,
job.
ma'am.
Okay.
Yes, thank you.
Thank you.
Thank
Thank
you.
you so much.
Thank you.
Thank you.